Bismillahirrahmanirrahim. Good evening, everyone. On behalf of Pakistan Society of Hepatology, I am Dr. Yasir Abbas Zaidi. I am Assistant Professor of Gastroenterology at Nishtar Medical University, Multan. I would like to mark the start of Plenary Session 3 of the second day of the first ever 3D virtual event in the history of Pakistan. I welcome all of our listeners, which include postgraduate trainees, physicians, gastroenterologists, and hepatologists from Pakistan and abroad. Today, it gives me immense pleasure to introduce today's faculty. The facilitator for this session will be our Honorable Professor Kashif Malik. He's the professor and head of department of Sheikh Zayed Hospital, Lahore. He's my mentor, and I'm very humbled and immensely proud to call him my friend. The chairpersons for this lecture are Professor S.M. Munir, Professor Mansoorul Haq, Professor Nasir Hassan Lak, and Professor Abrar Sheikh. So I would, with the permission of all, let's begin the session as we want to stay on time. There are certain house rules for the live speakers. I humbly request them to please follow the timeline. I understand that the topics are big, but time is our only constraint at the moment. For the viewers, our chat lines are open, and we are listening to you, everybody. And we are here to answer all of your queries. There will be a short Q&A session at the end where you can interact with the audience, with the list of panelists and our facilitator, and we will be more than happy to answer everybody's question. So today, the first talk of the session will be by Dr. Farooq Khan. The topic he will be covering will be autoimmune hepatitis and overlap syndrome, while highlighting the diagnosis and treatment of this tricky disease. He's a dear friend, a humble human being, and it gives me pride to call him my friend. He's working as a consultant hepatologist and hepatobiliary physician at the University of Leicester. He's trained in transplant hepatology at Leeds, and he has served associate tutor for the Royal College of Physicians, London. Dr. Farooq has immense contributions in the health system of Punjab, and he is a very recent recipient of the PSH Distinguished Academic Award 2020. He would enlighten us on this topic, and he will guide the latest trends in the treatment. This topic should be of great clinical significance and a good exam topic for our postgraduate trainees especially. So without further ado, I would like to request Dr. Farooq Khan to take the screen.
I am a consultant hepatologist in Leicester. It's a big topic, and I do think it's relatively difficult to cover it all in 20 minutes, but I think we certainly want to touch upon the diagnosis as well as the treatment difficulties that people get and how we can solve them in the light of evidence. Diagnosis, how do they present? What's the biochemical profile? Is there a standard tool? And does all of the patients that present with query autoimmune hepatitis need liver biopsy? Similarly, treatment-wise, when do I start? What do I start with? What's the second line? What are the difficult to treat groups? Are there any? And if there are, can I predict? Can I tell them that you are the ones who are going to run into problems? If I have managed to control it, when do I stop? And does everyone needs treatment? Okay. And we all know it's a chronic inflammatory condition. Women are more likely to have it than men. However, both the incidence and prevalence is rising. It's a bimodal age distribution, and there is a scientific reason for it. And let me explain you this. So if you look at this graph, so puberty, so below 20, you can see your DR3 HLA expression is at the maximum. And similarly, coming between this group, you could see, again, your DR3 and D4 HLA expression is at its maximum. So it's not really difficult to understand the why these young women, they either present at a very early age, so 20, below 20, and or they present after 40 years of age. Okay, now to make it slightly more interactive, and I think to keep the evidence and the interest going within this, I present you with one of my patients, Minnie, as you all know. Let's make it a case. It's a 20-year-old female, BMI of 22, so not obese, non-smoker, fairly limited alcohol, no past medical history, drug history, or over-the-counter medication, and there is no family history either. So she presented to my clinic with 6 weeks of fatigue, myalgia, arthralgia, and progressive jaundice. Let's have a look at a liver test, ALT 500, bilirubin 370. I think in Pakistan values, this would be in the order of 8 or 9, there and thereabout. ALPOS considerably high, albumin normal, so as a clotting. We did the viral serology, that is negative. And ANA raised, so as the SMA IgG was significantly raised, LKM, and we did all the other serology, it was ceruloplasmin normal. Presentation for autoimmune hepatitis, 30% with cirrhosis, 70% have either non-specific or they're actually asymptomatic. And if you look at this graph, New England Journal, you would see that 40% of these patients presenting acute hepatitis, but 30% are actually asymptomatic, which is also very concerning that 1 in 3 of my patients who present with autoimmune hepatitis are actually cirrhotic by the time they present. That is relevant. We'll come to that in a minute. Okay, and how do I simplify a scoring system? And there's an international criteria. We all use that, very common, you see time and time again, but I'll touch upon the salient features. Why? So we said that ANA and SMA are diagnostic for autoimmune hepatitis, but I also want you to look at is this. So the meta-analysis by Zhang group have shown that AMA and SMA, indeed, they're about 70% in autoimmune hepatitis, but look at NAFLD and NASH. We still get the positivity of around 40%. And similarly, in viral infections, really very diagnostic. So we then make a diagnosis, histology. And this is why it's important in that. Now, histology really definite. Should we do it for all? Let me just quickly take you through liver biopsy. Classic autoimmune, what you seems to get is lymphocytic infiltrate, just there. Then you get interface hepatitis within the surface there, as well as a portal tribe. And what you can see here is a classic hallmark of rosette formation and imperial polysis. Acute or severe autoimmune hepatitis, and the picture that you get here is very much a lobulitis array and a spotty hepatocytes. However, you don't really see or tend to see much of necrosis. On the other hand, when you see severe autoimmune hepatitis, this ballooning goes worse. You can see large hepatocytes in there, but you also see necrosis and bridging fibrosis in there. And this is really just to explain why it's relevant. Acute AIH, if your patient presents in a very acute setting, I think is relevant to actually biopsy it at that stage. There are 3 reasons. 1, to get the diagnosis right and to see if there's any overlap there. 2nd, if you were to consider transplant, then you're going to need it anyway. And 3rd, if at a later stage you were to consider treatment withdrawal and if the response is good, again, it's very useful to have a baseline histology. So yes, in our clinic, it's not uncommon that we request liver biopsy for these patients. Treatment, how do I treat it? What did I do with Millie? We started prednisolone 40 milligram, and we followed up a weekly at fortnightly intervals. What I normally do, I do the blood test of week 1, week 2, week 4, week 6. And what we find, the ALT responded, her billy came right down to normal, so as immunoglobulin. So excellent response, as you would expect, really, in a typical autoimmune patient of yours who's otherwise fit and healthy and not cirrhotic at that stage. So we called her back and we started azathioprine, 75 milligram once a day, and she remained in remission for 14 months. Okay, well, what's the evidence? Does everyone need treatment? The answer is yes. Treatment is life-saving as well as life-changing. So my previous boss, Dermot Gleeson, who's also written British Society of Gastroenterology Guidelines, as well as another paper in the Journal of Hepatology, has actually shown that untreated and the moderate severe AIH, if you do not treat these patients, the mortality is extremely high, with their 5-year survival reducing only to 50%. And similarly, if you do treat these patients, then the 10-year transplant-free survival is approximately 90% in treated group. So there is no doubt that you do have to treat these patients. You do have to treat them early and aggressively, if you like, and just to get better outcomes. Now, that said, is it really, when we say aggressive, does that mean higher dose steroids? We'll talk about this in a minute. Treatment strategies, by and large, we start 30 milligrams prednisolone as well as azathioprine in the combination with. However, you may notice that in Europe, we use 1 to 2 milligram per kilos, and in America, they go up to 50 to 60 milligrams. My trainees ask me a lot, why not be starting the higher doses as we do other, and I normally tell them this. So there is actually no difference between high and low dose outcome. If anything, the side effects are more. If you look paper, it's all, and paper, this is high dose, this is low dose, and if you look at the biochemical remission, 70 versus 64%, so not major difference really. But if you look clearly, the side effects profile is actually more on the higher side than on the lower. So therefore, start them 30 milligrams. If your patient is slightly obese or on the higher side of the weight, you could consider 40 milligrams, but 30 milligrams is fine. It's not a major problem. I'll usually leave them on 30 milligrams for at least 1 week, if not a couple of weeks. And if I see the blood trends coming down, their LFTs, I start reducing them 5 milligrams on a weekly basis. Right, what is the role of budesonide? What is a budesonide? Can we use it instead of prednisolone? The answer is yes. In which patients who have actually got good going side effects to prednisolone. But please bear in mind, this is the weakest side of the steroid, hence it's less efficacious. You start them at 9 milligram once a day. You could either do 3 milligram tablet once, twice a day, or 3 times a day. You could reduce it. However, most of the people will require 9 milligram if you start them. And it is approved for autoimmune hepatitis in quite a large European and non-European centers, but please bear in mind you cannot use it in cirrhotics, so not much role. Right, coming back to Minnie, it looks like she is in trouble and she was lost to follow-up. I'm not quite sure what happened. I think she went out of area for a bit. And she represented, this time back again with Billy of 35, that's a bilirubin, ALT of 600 and immunoglobulins of 32, so rather remarkable really. And so again, she was restarted with steroids, 30 milligram, azathioprine 2 milligram, but suboptimal response. And every time when we tried to put her steroids down, she just flares back in again. So the response was quite high. And at that point, I started to think about, is there overlap? And what you normally do, and I suggest you should do as well, please ask for MRCP to see if there isn't a good going PSC, primary sclerosing cholangitis. It's not uncommon to have that overlap. Anyway, hers was negative. We did 6-DGN, which is like a byproduct of the peripheral consumption of azathioprine metabolite. That was low, so we started allopurinol to increase the efficacy of azathioprine. But what next? Where do we go from here? Well, what's the evidence? This is where we start thinking about second-line therapy. Okay, please, before you go to second line, always check compliance. It is not uncommon that patient will not taking the tablets either rightly or at all. This was the case with our patient. She stopped taking medications completely. Celiac disease, please at least do a blood marker TTG. We know there's a significant evidence. Gideon Hirschfield from Birmingham has shown that drug malabsorption is a problem in patients who have got poorly controlled celiac disease. And therefore, it's worth checking whether they have got. And also there's a correlation because of the autoimmune genicity of both of these. Treatment failure. So let me just define this before we go. What is a treatment failure? What is unresponsive? Treatment failure is a group of patients who have achieved something, remission, maintained on remission, but they then have a flare. And the unresponsive are the one who 6 months of you, despite being trying the treatment, have never achieved a normal steady state, which all of you by now know that the standard now is not reduction in the ALT, the remission now defined as complete normal ALT or immunoglobulins. How do I treat it with? We now know that Minnie is not responding. We need to start her on some kind of therapy, which is second line. What do we do? So the evidence says 6 mg top urine. You can try that. And I'm just going to present you this paper where they tried 20 patients with azathioprine intolerance. 8 of them went into complete remission, and 7% have a liver histology. So please, it's worth bearing in mind, if your patient is intolerant of azathioprine, don't go straight to mycophenolate or tacrolimus or the second. I think it's not unreasonable to discuss with your patient and give it a go with 6 mg top urine. I have certainly experienced that, and at least in 1 in 4 of my patients, I would offer them 6 mg top urine before I jump into another. What is the role of allopurinol? We know that if you have the metabolites not there and there's an excess peripheral consumption, you would give allopurinol to reduce and increase the efficacy. What about mycophenolate? Certainly relatively safe, well studied, and well tolerated. 72% response when used as a first line with steroids. And that's worth remembering, really, because I think that's very useful. What about tacrolimus? I use that very often. 80 patients were tested in this paper, non-responders or intolerant to azathioprine, all comers, and they also found 72% complete remission. Very important to know that tacrolimus is better as compared to mycophenolate in patients who have not responded to azathioprine previously. So just a word of caution, if you have a patient who you started steroid, responded, you started azathioprine, response is poor, it's worth trying 6 mg top urine, and if that doesn't work, maybe it's reasonable to start thinking tacrolimus. Non-responders to azathioprine tends to respond better to tacrolimus than to mycophenolate. Just worth bearing in mind. Biologics, is there a role? Anti-CD20 rituximab, Tain et al. Presented this in Journal of Hepatology a couple of years ago. 22 patients, UK, Canada, Germany, retrospective analysis, fairly in early stages. 24 months before and after treatment, and there was a very clear remission and improvement in the group with ALT, AST, all numbers really, and there was also reduction of prednisolone and the doses flare. But I must caution here, rituximab is not for everyone. It's very much in the trial phases, and it's really reserved for big centers. So for level 1, sitting in the rural or GPs or general physicians, I think it's entirely reasonable to start them on steroids or azathioprine 6 mg top urine. But if your patient are non-responders or they're still having flares, then I think it's very reasonable to send them to higher centers to discuss mycophenolate or tacrolimus. And if that fails, then I think rituximab is relatively reserved for research centers or even transplant centers for that matter. But certainly, if you have failed tacrolimus, I think that patient should be in the books of transplant center. Right, coming back to Minnie, we really did not see much improvement there. She couldn't tolerate MMF, and therefore I switched her to tacrolimus. Unfortunately, her renal function deteriorated, and she was requiring multiple high doses of steroids, unfortunately becoming Cushingoid. We repeated a liver biopsy, and this time, along with interface hepatitis, there was some bridging fibrosis, so we know that she's heading towards cirrhosis. So what next? Should I do transplant? Well, we didn't. She didn't quite meet the requirement. Her UCAL score was not well below 49 at that stage. She had IV rituximab started, and luckily then achieved and sustained biochemical remission. Okay, how long do I treat them for, and when do I stop? Does everyone need treatment? Okay, How long do I treat them for? Well, there is actually no consensus. Let me present you some papers. The Dutch autoimmune working group, they have noticed that the relapse rate in the order of 60 to 90% at year 1, 3, and 5. And this is actually for those people who they stopped it after 2 years of biochemical remission. So your patients who have had achieved biochemical remission, so normal ALT immunoglobulins for about 2 years on treatment, those were the ones when they stopped the treatment at year 1, 3, and 5, about 60 to 80% had unfortunately relapsed. Okay. What Barbara Herold and the Karaja group from Sheffield, again from the unit I was trained for transplant, they have actually shown that between 41 to 55% of patients develop relapse, even whilst they achieved remission and on therapy. So not only that those patients who you stop the therapy would relapse, there is still a significant chance that your patients who have achieved remission on treatment within 2 years of their treatment paradigm, they would actually or can relapse. That is concerning. So how do I know who would do that or not? Can I select these patients better? The answer is yes. Clinical and biochemical remission is much more likely if there's a histological remission. So as we say, the hepatitis activity index of less than 4, the study presented where they looked at 22 patients over almost 6 years of follow-up, and they have found that if you have achieved histological remission, then you are much more likely, and in their group, there's a good 80% of patients who by 6 years follow-up remained in remission because they had histological. But really, can we do liver biopsy on every single autoimmune patient after 2 years of remission? Is it achievable? And then we know that liver stiffness, i.e. FibroScan, plays some role. So patients of yours whose FibroScan is 16 or above, I think it's just an indicator that perhaps they are not the right people to stop the treatment. Word of caution here, please do repeat their FibroScan after 2 years of treatment. You may be surprised that the people that you've labeled as cirrhotic at the beginning of it have actually are not cirrhotic because the FibroScan level falls down fairly significantly because the inflammation 2 years ago before the treatment may fall with it and explain. So I have certainly 2 patients where I repeated the FibroScan and the numbers have significantly come down while they were in remission. So who can I stop treatment? So type 1, non-cirrhotic, SLA negative, in remission for 2 years or more, 12 months of at least steroids free, and 3 to 5 years of azathioprine free. So this, I think this is relevant. Type 1, which has got ANA SMA positive, non-cirrhotic, SLA negative, who were in remission for 2 years or more, and certainly have no steroids in the last 12 months, and been on 3 to 5 years of azathioprine with no problem. These are the patients that you can sit down and without liver biopsy, maybe just do a FibroScan, where you could consider stopping their treatment. Last slide. Does everyone with autoimmune hepatitis needs treatment? Okay, there are only 4 categories that you need to consider really. What about cirrhotics? 1/3 of the presentation we've talked about this, and I think we should really start treatment without delay in this group, although when you start the treatment, discuss with patient, and there has to be very clear treatment goals, really. And the idea is to see if there be transplant-free survival as well as biochemical remission. What about burnt-out disease? So inactive cirrhotics, as I call them, with normal LFTs. So these are the patients who we know have got autoimmune hepatitis, who we know have got burnt-out disease. They are cirrhotic, but their LFTs are normal. I don't think there's much point in actually treating this group. And if you see EASL guidelines would actually say the same. The impact on overall outcome is generally thought to be very low for these groups. So I think rather than achieving and looking for side effects of the drugs, just monitor them fairly closely. So no for burnt out disease. What about acute severe autoimmune hepatitis, like your fulminates? Now this group, and I think the jury is still out there. these are the patients who usually are in high dependency hepatology units or ITU, particularly if they're permanent. You do want to contact the transplant center. And I think the aim here isn't treatment and see the response. The aim is to try and get to transplant center as soon as, although I think most of us, and I have myself, we would have started these patients on treatment and to see if they would just escape the transplant. And the last group is decompensated. You really have to be very cautious with them. And I'm happy for the treatment to be started in decompensated groups, but I think it's very relevant and worth bearing in mind that contact the transplant center first and tell them we are going to start the treatment and make that decision. Are they going to be or likely to be transplant candidate or not? Because there may be that they get worse or deteriorate even further when you start them on immunosuppression, in which case that decision is really important whether they are transplant candidate or not, because this would mean you either palliate them or you will refer them if they deteriorate for transplant. Okay, I'll finish here. Thank you very much, and I'll take further questions in this session. Thank you.
Brilliant talk, Dr. Farooq. We loved every minute of it, and we are happy that Minnie was saved from transplant. So we would like to thank you for this wonderful talk. It helped clear many complex concepts of mine, and I'm sure of everybody who was listening. So our next talk for today is Dr. Ananta Shrestha. He will talk about non-cirrhotic portal hypertension. He's an honorable delegate from the Kingdom of Nepal. Dr. Ananta is a dedicated new generation hepatologist who has already shown his promise. Sheikh Hasina Wajid herself awarded him with the prestigious Prime Minister's Gold Medal of Bangladesh for the year 2010 for his academics in Faculty of Medicine. He is currently the secretary of Nepalese Association for the Study of Liver and executive committee member of South Asian Association for the Study of Liver. And he has gladly accepted to deliver lecture on non-cirrhotic portal hypertension. Dr. Ananta, please take the screen.
Ladies and gentlemen, a very good evening. My greetings from Kathmandu. At the outset, I would like to thank the organizing committee for allowing me to have a talk in this August gathering. In the next 20 minutes or so, I'll be talking about non-cirrhotic portal hypertension and especially focusing on non-cirrhotic portal fibrosis or idiopathic portal hypertension. I have nothing to disclose. I intend to clarify that not all portal hypertensives are cirrhotics. And I would like to discuss about different causes of non-cirrhotic portal hypertension and focus on idiopathic portal hypertension, about its natural history, different complications, and management-related issues. Now, let me start my talk with a case. Now, this is a 19-year-old female which presented to me about 10 years back with upper GI bleeding for a day. There are no pre-existing comorbidity, negative family history for liver disease, and no history of neonatal umbilical sepsis. She had splenomegaly. At endoscopy, she had large gastroesophageal varices type 1 with red color signs and recent stigmata of bleed. She underwent band ligation and 3 other subsequent sessions till eradication. On labs, she had thrombocytopenia. Liver function was very much preserved with normal albumin and prothrombin time and normal bilirubin levels. Biomarkers were negative. Autoimmune and copper workups were negative. Ultrasound showed liver with sharp edge and smooth surface. Increased periportal echo and splenomegaly and trace ascites. Shear wave elastography showed elastography value of about 10.7 kilopascal, which was a bit low for the degree of portal hypertension she had. A differential diagnosis were cryptogenic liver cirrhosis, non-cirrhotic portal hypertension, which could be because of extrahepatic portal vein obstruction, or non-cirrhotic portal fibrosis, or IPH, or congenital hepatic fibrosis. Our CT splenopodogram showed patent and dilated splenoportal axis, which excluded the diagnosis of EHPVO. Now we are left with either cryptogenic liver cirrhosis or NCPF versus congenital hepatic fibrosis. Liver biopsy showed maintained lobular architecture, second portal tracts with sclerosis, periportal fibrosis, and there's no bridging fibrosis or cirrhosis. So this was very much suggestive of NCPF or idiopathic portal hypertension. Now, non-cirrhotic portal hypertension in general means conditions where there are unequivocal evidence of portal hypertension in absence of liver cirrhosis. This could be because of a number of causes. There are a big list of etiologies for non-cirrhotic portal hypertension, but then extrahepatic portal vein obstruction is the commonest cause of NCPH, at least in case of Southeast Asia. There could be Budd-Chiari syndrome or vascular diseases, including IVC obstruction and cardiac diseases. Among hepatic causes, there are different causes, but then IPH needs a special attention. And my talk today will be limited to idiopathic portal hypertension or non-cirrhotic portal fibrosis. The reason why I chose this topic is very ambiguous. There are a number of nomenclatures given. The natural history is confusing. It is different from other causes of non-cirrhotic portal hypertension, especially that of EHPVO. The management strategies are a bit different. Now, this is a very ambiguous term in terms of nomenclature because Asians call it as a non-cirrhotic portal fibrosis, whereas Japanese call it as idiopathic portal hypertension, and European and American call it as hepatoportal sclerosis. Recently, a new entity or new term has been coined, which is called as portosinusoidal vascular disorder. And there are less known other nomenclatures as well, which adds much of the confusion and ambiguity. Now, there are many diagnostic criteria as proposed from the PASL by Japanese group and all. This one is from Scotland, and this is much more widely used, and it's a very practical one. This criteria requires clinical sign of portal hypertension, exclusion of liver cirrhosis by biopsy, exclusion of other etiology of chronic liver disease, including hepatitis B, C, NAFLD, and others, exclusion of other well-known established cause of non-cirrhotic portal hypertension like congenital hepatic fibrosis, sarcoidosis, and cystosomiasis, and needs a patent portal system and hepatic veins, excluding EHPVO as well as Budd-Chiari syndrome. However, this diagnostic criteria has got certain disadvantages. The first is it excludes commonly coexisting conditions like hepatitis B, C, and NAFLD. As we know that in urban population, nearly about 1/3 of our population will have NAFLD, and it has got a fairly good chance that any patient with NCF, PF might have 30% chances of having fatty liver. Or in endemic region, they may also have existing hepatitis B or C, which probably might not be contributing to the liver disease. But in such cases, just merely by having these diagnoses, NCPF, if it really exists, would be excluded. The second is current diagnostic criteria requires portal hypertension, but it has been increasingly recognized that histological feature of NCPF tends to occur early in course of disease where portal hypertension has not yet developed. So this diagnostic criteria will probably exclude early cases of NCPF or IPH. So recently, Valdi group has proposed a new terminology called portosinusoidal vascular disease. The reason why the term coined this term is in NCPF or IPH, the lesion lies in the portal tract or the portal triad and the sinusoids. It's the obliteration of the portal tract and the nearby sinusoids. So this term was coined, and the concept related to portal sinusoidal vascular disease is a bit different from the previous concept. In this current concept, they tend to include cases who have histological features of non-cirrhotic portal fibrosis or portosinusoidal vascular disease, but without established portal hypertension. Or those patients who have portal hypertension, but without classical features of histological feature of NCPF. And they also tend to include overlap or cases which have got coexisting viral hepatitis B, C infection, or NAFLD. So this concept of PSVT encompasses a broader range of broader group of people with non-cirrhotic portal fibrosis, which otherwise would have been excluded by previous diagnostic criteria. The currently proposed diagnostic criteria is absence of cirrhosis in liver biopsy, along with one specific histological sign or presence of one specific feature of portal hypertension. In absence of specific feature of portal hypertension or specific histological feature, you need combination of both in absence of cirrhosis and biopsy. So specific signs of portal hypertension includes varices or portal systemic collateral site imaging. And non-specific features of portal hypertension are ascites, thrombocytopenia, or splenomegaly. There are three hallmark histological features of PSVD. There are obliterative portal venopathy, nodular regenerative hyperplasia, and incomplete septal fibrosis. Now, this is normal portal tract of a normal liver. You can see a beautiful portal vein, hepatic artery, and bile duct, and surrounding normal parenchyma. Now, this is what actually happens in obliterative portal venopathy, where the portal tract is totally replaced by fibrotic tissue, and portal vein is very much chinked and almost obliterated. Second feature is regenerative nodular hyperplasia, when the normal-looking hepatocyte tend to form a cluster, but there is devoid of any fibrosis surrounding the nodule. Now, in cirrhosis, there are regenerative nodules which are surrounded by fibrosis, but in regenerative nodular hyperplasia, there are nodular arrangement of hepatocytes, but without surrounding fibrosis. The third histological hallmark is incomplete septal fibrosis. Now, these fibrotic strands, they spread out from the portal tract, but then they end blindly in the normal hepatic parenchyma. In cirrhotic, these septal or these fibrous septa tend to join another portal tract or hepatic vein, thereby forming a bridging fibrosis. Now, the absence of this bridging fibrosis excludes the diagnosis of cirrhosis and gives the hallmark diagnosis of portosinus cerebrovascular disease or idiopathic portal fibrosis or NCPF, whatever you may call it. Now, there are certain salient features of NCPF, which includes predominantly portal hypertension, hypersplenism with preserved liver function, absence of liver cirrhosis. These patients tend to tolerate bleeding episodes very well. Ascites are common during bleeding episodes, but it doesn't portend a poor prognosis. Liver stiffness, as in our case, tends to be very modest, despite significantly high portal hypertension. Hepatic venous portal gradient does not reflect portal pressure in case of NCPF. It may be normal or maybe mildly elevated, though splenic pulse pressure and portal pressure tends to be high. Now, coming back to our case, the patient was lost to follow-up for about 3 years after the first episode of bleeding and eradication of varices. She then presented a third trimester of pregnancy. Fortunately, she delivered a 3.5 kg baby with its cesarean section. But during postpartum period, it was complicated by severe ascites requiring albumin, large volume paracentesis, and diuretics. 3 months postpartum period, she had severe pain abdomen, again landed up in an emergency department. An ultrasound showed portal vein thrombosis, occluding nearly about 50% of MPV, or main portal vein, and extension into proximal superior mesenteric vein. After endoscopic screening and making sure that her varices were eradicated, anticoagulation was started with dabigatran. SMV extension of thrombus resolved, but size of PV thrombus remained unchanged. Anticoagulation was stopped after a year. The natural history of NCPF is interesting. 60% of these patients are symptomatic or diagnosed while evaluating for cytopenias or abnormal liver function, ecotexture, or detection of endoscopy, varices at endoscopy. However, 40% of these patients are symptomatic. Mainly, they present as bleeding. Over long term, they either have recurrent episodes of variceal bleeding, they tend to have portal vein thrombosis, they tend to decompensate in a small number of patients, and may have compromised survival. Now, these patients with NCPF or idiopathic portal hypertension tends to have very prominent portal hypertension. Despite primary prophylaxis, nearly about 25% of these patients would bleed within first 5 years. And if you look at the rebleeding rates, these are very high. Nearly about 40% of these patients and 45% of these patients eventually rebleed after the deployment of secondary prophylaxis by 5 years of follow-up. Portal vein thrombosis is fairly common, as we have seen in this case. Nearly about 40% of these patients will develop portal vein thrombosis after diagnosis within 5 years. And this is particularly true in case who have HIV co-infection. Fortunately, 50% of these patients would recanalize with anticoagulation. In the rest 50%, it remains stable or may even progress. Though liver function is very much preserved in case of NCPF, over due course of time, about 20 to 30% of these patients might develop features of decompensation, as evidenced by refractory ascites, hepatic encephalopathy. However, hyperbilirubinemia and coagulopathy are very much uncommon in NCPF or IPH, and they tend to have lower CTP score and lower MEL score. This usually occurs as a result of subcapsular parenchymal collapse and atrophy. Now, this is one of the staging systems that is proposed by Nakanuma in 1991, in where in stage 1, there's no subcapsular parenchymal atrophy and the liver volume is maintained. In stage 2, there is subcapsular or peripheral parenchymal atrophy, but the liver volume again is preserved. In stage 3, there's marked subcapsular parenchymal atrophy along with liver atrophy or decrease in the liver size. In stage 4, there is occluding thrombus in the portal vein. So it's usually in the stage 3 and stage 4 that the patient usually lands up with refractory ascites or which is a liver insufficiency requiring a transplant. Now, if you look at the natural history of these patients, the survival of this patient is pretty good. It's about 84% at about 15 years from diagnosis, which is pretty good. Some patients who have persistent ascites at presentation are associated with the immunological disorder tend to have poor prognosis. If you look at the mortality, the major cause of these patients who die because of bacterial infection or liver failure in about 1/4 of the patient. Some people die because of uncontrolled variceal hemorrhages or hemorrhagic infarction of small intestine, secondary to mesenteric vascular thrombosis. Etiology is largely unknown, but then there are certain conditions associated with PSVD or ulcerative bottle fibrosis. These include blood disorders, prothrombotic conditions, immunological disorders like SCV, autoimmune hepatitis, HIV, celiac disease, infectious conditions like repeated GI infections, which particularly may have very important role to play, at least in Southeast Asia, and different drugs and genetic conditions. There are different hypotheses regarding how non-cirrhotic portal fibrosis develop or evolve. Now, this is one of the Japanese hypotheses where it's proposed that TGF-beta-1 influences endothelial cells into myofibroblast-like cells, which produces extracellular collagen. Now, this collagen would eventually lead to fibrosis around the portal vein and cause obliterative venopathy. Now, dual theory was proposed by European colleagues, and they proposed that it's the increased splenic venous inflow that leads to hyperdynamic circulation, along with obliteration of small and medium-sized branches of portal vein. This leads to pre-sinusoidal portal hypertension, NCPF, and IPH. A third interesting theory is unifying hypothesis, which tends to explain the occurrence of NCPH or EHPVO by a single pathogenetic mechanism or as a spectrum of the single disease. Here they propose that the precipitating event, which could be infection or trauma, and there's a prothrombotic predisposition, which could be genetic or acquired. If the nature of insult is mild or recurring, that occurs in childhood or adolescent, the usually insult or thrombosis in the peripheral branches of the portal vein. But if it is severe or progressive, occurring in early neonatal period, it causes thrombosis the main portal vein, leading to EHPVO. So this theory or this hypothesis explains the pathogenesis for both NCPF and EHPVO as the same part of the spectrum. Management of IPH or NCPF is pretty straightforward in terms of the number of elements that we deal with. The main element that we deal with is varices. Either we prevent bleeding or we manage the bleeding. It is usually done by endotherapy, sometimes requiring surgical procedures and sometimes intervention radiology. Portal biliopathy is not as common as what you see in non-cirrhotic, extrahepatic portal vein obstruction, but then it does occur in some patients. Sometimes features of decompensation may warrant liver transplantation. The management of varices in IPH is not much different from that of cirrhotics. Those patients who have bled would require endotherapy with EVL, with our beta blockers. For GOV type 2 and IgV, glue injection will be warranted. For PSG bleeding, APC, and for ectopic varices, sclerotherapy or glue injection is given. For this patient who have never bled, either band ligation or beta blockers can be given as a primary prophylaxis. If it if we if immunotherapy succeeds in eradication of viruses, then it's well and good. If it doesn't, or there's uncontrollable bleed that is not secured by endotherapy, then shunt surgery is an option. Management of portal biliopathy again needs to be discussed because some patients do actually develop portal biliopathy. For those patients who have cholangitis, will require urgent ERCP and decombination of the biliary tree. If there are stones, it has to be taken out. If there are strictures which are dominant, they should be dealt with balloon dilatation and stenting, which in many cases are likely to be failure. In such cases, if there are shuntable veins, they should undergo shunt surgery. The surgery is usually done as a two-stage procedure. First step is shunt surgery. By decreasing portal pressure, it is expected that the stricture might improve. If it doesn't, it might require biliary diversion in terms of hepaticojejunostomy or SG anastomosis. For those patients who do not have dilated ducts with just isolated increase in alkaline phosphatase, they can be followed up. Surgical procedures should be avoided as much as possible because 50% will develop delayed complication. Coming back to our case, our patient again presented about a year back with variceal bleeding from small residual varices, which was not controlled by endotherapy. She was taken up for distal splenorenal shunt. Surgery was uneventful, but during 6 months, she developed proteinuria and was diagnosed to have glomerulonephritis. Now, this is a very interesting paper again from India, which followed about 41 patients of NCPF who underwent surgery, and 47 developed delayed complication, including encephalopathic glomerulonephritis and fistula. There's another study done from AIMS again, about 200 NCPF patients who underwent distal splenorenal shunts. 32% developed glomerulonephritis over 5 years of period. And the commonest cause of glomerulonephritis were mesangial-proliferative and mesangiocapillary glomerulonephritis. There are very limited data regarding outcome of a liver transplant in NCPF. However, the data so far shows a good outcome, about 94% survival, about 54 months. And there are reports of occasional disease recurrence in the graft. So, ladies and gentlemen, to summarize my talk, NCPF or idiopathic portal hypertension or PSVD is an outcome of various portosinusoidal disease involving small and medium-sized portal vein radicals. It presents with predominant portal hypertensive features. It should be considered as a differential diagnosis of early cryptogenic liver cirrhosis. Prognosis is generally better than cirrhotics, but natural history is complicated by repeated bleeding episodes and portal vein thrombosis. Shunt surgery is associated with delayed complication in as much as 50% and should be avoided as much as possible. A small proportion of NCPF will go on to develop liver insufficiency requiring a liver transplant. However, the outcome of which is at least as good as in cirrhotics. Thank you very much.
What a great lecture on non-cirrhotic portal hypertension. I'm sure everybody must have enjoyed his talk as much as I did. Thank you, Dr. Nanta. It was a pleasure having you with us, and hope we will be graced by your presence in our upcoming conferences. So, without wasting any more time, next on today's menu is a very crisp and energetic personality on the GI scenario. I would like to introduce Dr. Adnan Syed from USA. He will deliver a lecture on cholestatic liver disease and will highlight the principles of management. Dr. Adnan Syed is a faculty member in the Division of Gastroenterology and Hepatology with the Department of Medicine and is Chief of Division of Gastroenterology and Hepatology, William S. Middleton Memorial Veterans Hospital. He also serves as the Medical Director of the VA Liver Transplant Program and the Liver Transplant and Hepatitis Liaison at the VAH. He is a member of the Executive Committee of the National Medical Advisory Board of American Liver Foundation and the Chair of the Wisconsin Chapter of the Medical Advisory Committee, American Liver Foundation and Associate Editor of Clinical Liver Disease. Dr. Syed has served on the Clinical Guidelines Committee of the American Association for the Study of Liver Diseases. He currently serves as the Finance Committee and Public Policy Committee of the American Association for the Study of Liver Diseases, and he's also a fellow of the American Association of the Study of Liver Diseases. Wow, that's so much SLD in one man. So please welcome Dr. Adnan Syed. Please take the screen.
Hello. Thank you for the kind invitation to the Pakistan Society of Hepatology. My name is Adnan Saeed. I'm a physician in gastroenterology, hepatology, and liver transplantation at the University of Wisconsin in Madison. And the topic of my talk today is from NAFLD to MAFLD, all you need to know. I'm recording this, and it's unfortunate that we could not be there in person, but if you have any questions, I will call in, and please feel free to email me anytime. One of the advantages of a virtual presentation is the organizers can always fast forward this if they get bored. Here are my disclosures. And here are the objectives for today's talk. We're going to discuss the proposal from the liver community about changing the nomenclature of NAFLD, non-alcoholic fatty liver disease, to MAFLD, or metabolic disease-associated fatty liver disease, and discuss why the impetus behind it and the reasoning. So as this audience very well knows, NAFLD is not a new diagnosis. Nor was it first discovered by the Mayo Clinic. People had always recognized fatty liver disease associated with obesity and diabetes, although most of the attention was towards alcohol, and that's still the perception of the lay public. The Mayo Clinic, however, was the first to codify this in 1980 when they described this entity histopathologically that looked like alcohol, but was clearly not associated with alcohol. They took 500 patients seen there with good records with steatohepatitis on histology. 200 clearly had alcohol excess and therefore were excluded. 200 had incomplete records. And of the rest, they found 20 patients with complete records, clearly no history of alcohol, who had liver biopsy findings showing steatosis, lobular inflammation, necrosis, and they coined this as non-alcoholic steatohepatitis and NASH. So that's where the current paradigm of NAFLD comes from. It is dichotomized into NASH, which is thought to be the progressive form of this disease, at least as defined histologically. As you can see on the left, it is associated with steatosis, changes of ballooning, and lobular inflammation. And then NAFL, what used to be called simple steatosis, where the only changes are steatosis, thought to be relatively more benign. And the impetus to change the definition or the nomenclature of NAFLD to MAFLD is not new. People in the liver community have talked about it for at least 2 decades, if not more. But there's definitely fresh motivation now, and I'll discuss some of the reasons why. Regardless, EASL got together a panel of about 400 plus experts from 22 different countries and convened them in a consensus panel. And they published their findings from the consensus panel. And they suggested that the nomenclature of NAFLD should be updated to MAFLD, or metabolic associated fatty liver disease. The diagnosis should be based on the presence of metabolic dysfunction, not the absence of other conditions. A recognition that MAFLD can coexist with other liver diseases, and that a reference to alcohol should be removed from the acronym, like it exists currently. And that there needs to be recognition about contribution of alcohol to MAFLD as well, and research in this categorization. And then they voted. So what are the results of the vote? An overwhelming majority, 72% of the participants, support changing the name from NAFLD to MAFLD, at least in this panel. About 17% wanted to call it MEFLD with an E, not a big difference there, and then 10% went rogue and had some other suggestions, and I'm not sure what they are. So before we go further, I would like you to consider a multiple choice question and see what do you think, which of these 3 cases meet criteria for MAFLD. So case A, or the first case, is a 57-year-old female with elevated liver enzymes. She is obese by BMI and waist circumference criteria, does not drink alcohol, does not use medications, She does not have diabetes, hypertension, or dyslipidemia. Her ultrasound is normal. The second case, B, is a 30-year-old male with, again, elevated liver enzymes. He's got a normal BMI. He's got no evidence of diabetes, hypertension, or dyslipidemia, no medications. He does drink about 3 servings of alcohol per night. And on ultrasound, he does have an echogenic liver. And then case C is a 45-year-old male who's got an elevated liver enzyme again. He's obese by BMI waist circumference criteria. Drinks maybe 2 drinks per week. He also has hypertension, which is well treated, and he also has an echogenic liver on ultrasound. So I think if the organizer want to pause, get audience response, they can go ahead and do that. So before I go into what the right answer might be, this is what the panel defines MAFLD as, or proposes the definition of MAFLD as. The first part is, of course, you have to have a positive diagnosis of fat or steatosis in the liver, detected either by imaging or liver histology. They did include blood biomarkers and scores, but I don't think these are sophisticated or validated enough to be accurate yet. So from my perspective, it's imaging and histology, which will help me make the diagnosis of steatosis. If this steatosis exists in the presence of being overweight, which is defined very conservatively as a BMI of over 25 or over 23 in Asians, then you can make the diagnosis of MAFLD, which would be a lot of people. The other big group is anybody with type 2 diabetes who has steatosis can also be called MAFLD. The third group is people who have lean or normal weight by BMI criteria. In order to diagnose them with MAFLD, you need at least 2 or more metabolic abnormalities, which can include elevated waist circumference, as defined by the standard metabolic syndrome criteria, elevated blood pressure, high triglycerides, pre-diabetes or insulin resistance, and elevated highly sensitive CRP level. So based on this definition, from the cases that we discussed, I think case C would tend to be the correct answer. This is somebody who has a echogenic liver on ultrasound, so likely steatosis. That's the first one. They have obesity and in addition hypertension. You don't need both. So this would meet the criteria for MAFLD. Case A, they have obesity, but they have a normal ultrasound. So while they may turn out to have MAFLD with further workup, current diagnostic criteria do not support them as having MAFLD. And then case B, this is a gentleman with an echogenic liver, but has a normal BMI, no metabolic syndrome, no diabetes, does drink enough alcohol, but this is likely alcohol-associated liver disease, of course. And then how do you diagnose MAFLD in the setting of cirrhosis? As we know, steatosis often disappears in the setting of cirrhosis. In the setting of cirrhosis, the panel said that there should be evidence of metabolic risk factors as described previously, and then at least one of the following: documentation of fat on a previous liver biopsy or historical documentation of steatosis by imaging. So why the name change? The main reason why it has always bothered people in the field is while the name was useful initially to take attention away from alcohol 40 years ago, by now there is enough recognition that there are known risk factors. And the name tells you what it is not, but it does nothing, at least for the general medical community, and definitely not for the lay public, in telling you what it is from. It tells you it's not from alcohol. Some people view that as pejorative. It takes away attention from positive diagnostic associations, which I think are useful in thinking about any disease process. And it leads to confusion about the role of alcohol intake, which we know coexists. So you can have fatty liver disease, MAFLD, or NAFLD, along with alcohol intake or alcohol-induced liver disease, such as like Hep C, and the name leads people to believe it may not be so. Is there a precedence for this name change? Well, there is for many diseases, and even in liver disease, there are a couple of examples. So PBC, or primary biliary cirrhosis, was changed to primary biliary cholangitis not too many years ago. At least they kept the acronym the same. But it's not a fast, rapid process. PBC was officially named as such way back in 1949 by the Canadians. Not a well-known name. Even people in my clinic hated being coined with a disease that had cirrhosis in it when I would tell them they don't have cirrhosis. Eventually, after many discussion and from patients, advocates, and support groups in the medical community, the European EASL and the ASLD, the American Association of Liver Disease, voted for the name change, endorsed it in 2014, and then WHO had designated it as an acceptable name change in acronym in 2016. So you can see that the field of NAFLD and MAFLD will have to go through that process. Other things to consider include ICD classifications, diagnostic and billing codes, all important things to consider before this is accepted and used. The other reason that the board, besides defining the MAFLD is proposed the name changes to allow further recognition for the heterogeneity, the variety of conditions that can lead to MAFLD, that this is not one single disease, as we may think, or even a dichotomous disease. So what do they mean here? So currently, a lot of the way research has gone in this area, particularly therapeutics research, is using the histopathologic diagnosis of NASH and NAFLD. And while it is useful, we know it is a final common pathway of heterogeneous disease entities which may operate down several different pathways. And sometimes those get ignored at the cost of looking at the final common pathway. So we know there's a wide spectrum of disease severity and progression rate. Most people that have NAFLD have steatosis. NASH occurs only in a few. Some are diabetic and some are not. Some are lean and some are not. And we know that as opposed to other chronic liver diseases, liver cancer occurs in the absence of cirrhosis more commonly in NAFLD than, for example, in hepatitis C, maybe 3 times as common. And we see progression and regression in both simple steatosis or NAFLD and NASH. So understanding the underlying pathophysiology, the drivers of the liver disease are more likely to lead to better and more effective treatments for the liver disease component of this disease, at least, rather than just focusing on the phenotype of it, which is NASH or cirrhosis or NASH fibrosis. And another example in the liver disease community is non-A/non-B hepatitis. So this was the name given to hepatitis C before the genome for Hep C was discovered in 1989, and we could make an accurate diagnosis. In the subsequent decades, that has led to, of course, a great understanding in the disease, in the diagnosis of this disease, research, and ultimately specific treatments for the disease, which is something that the field of fatty liver disease aspires to. And it is a complex disease. It is a metabolic, multi-system disease that has many components. The liver is just a somatic manifestation of the metabolic syndrome, as people like to say, and that's quite true. There are CNS changes in hormones in the pituitary, as well as satiety hormones, hunger hormones, different changes in the adipose tissue, the effect of insulin-resistant adipokines, changes in the muscle, of course, in the liver as well, and then the effect in the intestines of both the microbiome, bile salts, and alike, which affect development of the liver condition. And there's a great source of heterogeneity based on your age, your gender, hormonal status, ethnicity, as well as environmental factors, which include diet and alcohol and smoking and genetics and your metabolic status as well. So that if we consider a patient who has NASH with stage 2 fibrosis, according to current classification, that patient can have very different risk factors. So that patient may be looking like patient 1, with a major component of their liver disease is due to environmental risk factors, with a smaller component of genetic syndrome. Patient 2 is somewhere in between. And then patient 3 has a big genetic predisposition to NAFLD and maybe a small component of environmental factor. Histologically, all three may look the same, but you would not expect all three to respond to similar treatments or to be treated the same. And that makes total sense to me. So here's another multiple choice question. Choose the best response regarding NAFLD. A, the G allele, which is the risk allele in this polymorphism in PNPLA3 gene, which is associated with fatty liver disease, is common in Hispanic origin patients and least common in East Asians with NAFLD? Or is it B, that the G allele in PNPLA3 is associated with increased risk of metabolic syndrome? Or is it C, the risk of NAFLD is increased by a diet high in fructose or sugar-sweetened beverages? Or is it D, that proteobacteria are depleted in the intestine in patients with steatosis? So I will let the audience respond to some work here.
Yeah.
And I think the correct answer is C. It has been clearly shown by various studies, including recently from our group, that a diet high in sugar-sweetened beverages and fructose is really associated with increased risk of NAFLD. The G allele in PNPLA3 is common in Hispanics, but it is common in East Asians as well, and as common as it is in Caucasians. The PNPLA3 gene is also associated with fatty liver disease, but not with risk of metabolic syndrome. These are separate risk factors, and I'll show you some data. And then the microbiome is associated, but proteobacteria are actually linked or increased in the intestines in patients with steatosis. So genetic variations vary across ethnic groups. There are several genes that have been associated with non-alcoholic fatty liver disease that do account for a significant increase in risk. The most well-studied of this is PNPLA3, which was first described in 2008 in association with this disease in the Dallas Heart Study associated with NAFLD. It is most frequent in U.S. studies in Hispanic individuals, 49% polymorphism in this gene, followed by non-Hispanic whites, and then least in African Americans. In a study from Hong Kong, this polymorphism was found to be as common in East Asians as in, or even more common compared to Caucasian individuals. And then finally, as I was mentioning, PNPLA3 increases the risk of steatosis and even steatohepatitis and fibrosis in NAFLD, but also in other liver diseases like alcohol and even Hep C. It is associated with reduced hydrolysis of triglycerides and possibly other changes in the transport and handling of lipids, but it is not through the pathway of development of metabolic syndrome. So here's that really nice Asian study I was showing you from Hong Kong, looking at the G allele in PNPLA3, and it is associated with the increased risk of developing NAFLD. You'd see on the left three bars are patients who have fatty liver disease in the absence of metabolic syndrome. So their risk is lower of developing fatty liver disease compared to patients with metabolic syndrome, which are those on the right three bars that you see here. But even within this group, the presence of the GG polymorphism is associated with 3 times the risk of NAFLD compared to those who are so-called wild type. Metabolic syndrome is, of course, a stronger risk factor, and there the PNPLA3 gene may make a difference, but the difference is not as strong. Alcohol consumption and NAFLD, of course, are not dichotomous. Research and even clinically, people have used this average daily intake of 30 grams daily for men and 20 for women as sort of being risk factors that can lead to alcohol-induced liver disease above this, and below it, not associated with risk factor. And we know the truth is various shades of gray. So we know there are patients with fatty liver disease who drink less than this, but may have more progressive liver disease even with lower levels of alcohol intake. And we know that there are patients with NAFLD who drink heavily as well, and that these conditions may be synergistic as well. So the impetus now is to allow the use of alcohol in the diagnosis of metabolic associated fatty liver disease, and actually to study the condition further to further stratify the risks. The microbiome and NAFLD is an area of increasing research, and basically right now the microbiome is hot, and everybody's studying the microbiome from any condition under the sun. But clearly, the liver is exposed to the intestine and the microbiome, and there has been excellent groundbreaking research continues to be on the role of the microbiome in the area of NAFLD. Dysbiosis, the presence of unhealthy bacteria in patients who develop liver disease, lead to increased intestinal permeability and the activation of toll-like receptors by products of these bacterial toxins like endotoxin, lipopolysaccharide. These bacteria also produce ethanol in the gut. They affect bile acid metabolism, produce choline, all of which may cause steatosis, inflammation in the liver. And so this is an area of great research these days. And then finally, in the area of heterogeneity, I think we all recognize now that NAFLD is not a dichotomous liver disease, but rather it's a very dynamic liver disease. So NASH can revert back to simple steatosis with or without specific therapy. And of course, NAFLD can progress to NASH as well. There are studies of natural history, including, for example, here shown in this paired biopsy study, where they at baseline looked at 26 patients who had NAFL or simple steatosis, 10 who had NASH, followed them up histologically, and at follow-up, 27% of the patients with NAFL progressed to NASH, but over 50% with NASH no longer met the criteria for NASH and instead were classified as NAFL. And even fibrosis was not static. So it progressed in 42%, but spontaneously regressed in 25% and remained stable in about a third. And this is well illustrated in some of the recent large randomized controlled trials, and there are many of these, and these are placebo-controlled. And in the placebo arm, who did not receive any active treatment, the regression rate of fibrosis histologically varied from 5% to a high of 22%, averaging around 10 to 20%, which is quite a high placebo response rate. So NAFLD is a very dynamic liver disease. There is a great degree of natural fluctuation between the steatosis, NASH, and even fibrosis on longitudinal follow-up without specific treatment. There's an effect of exogenous and lifestyle intervention on these. And so a disease that is not as rigid in dichotomy, does not require liver biopsy to classify it, would be useful. And I think MAFLD may fit the bill. So you can define MAFLD in the presence of steatosis on imaging or biopsy and the presence of these metabolic risk factors. And you can further delineate the liver disease risk by defining fibrosis, which does not necessarily require biopsy. So we look at examples, including elastography and imaging in the workshop tomorrow. And future directions, of course, are in all these areas we talked about defining disease subtypes, natural history, variation, and response to therapy. And the final part of the consensus trial was refining our clinical trials, stratifying patients better, maybe looking at our endpoints of treatment. So what's the concern with the clinical trials? So before I get into it, let's do one final multiple choice question. So which of the following do you think is correct regarding therapy for NAFLD? So A, is it vitamin E, 800 units per day, is FDA approved for treatment of NAFLD only in non-diabetics? Is it B, weight loss of 70 to 10% of body weight can lead to resolution of NASH? Is it C, obeticholic acid has received accelerated and preliminary FDA approval for treatment of NASH with fibrosis in June of 2020? Or is it D, most current NAFLD pharmacotherapeutics in phase 3 trials have chosen improvement in liver enzymes and resolution of steatosis on imaging as their primary therapeutic endpoint? So please select your best answer. And I think the weight loss answer is the correct one. It's clearly shown that anywhere to 7 to 10% of sustained body weight loss can lead to resolution of NASH and even reversal of fibrosis. But I mean, E is, can be used in non-diabetics with NAFLD, but it is not FDA approved. It is off-label use. Obeticholic acid did not receive accelerated FDA approval for treatment of NASH fibrosis. The trials are ongoing.
I apologize for the unexpected. We are having some technical difficulties. So the lecture was terminated prematurely. For those who are interested in the lecture, it will be available after a few hours on our website, the full version. So we will not let these small difficulties stop us from progression. We are a very progressive nation and a very progressive society. So we have a very good talk coming up. The fourth speaker for today is Dr. Nadeem Tehami from UHS, United Kingdom. He will deliver his talk on cholestatic liver disease, highlights on clinical management. A few words about Dr. Tehami for those who don't know. He has been with us for quite some time now and has become a household name in the GI fraternity. Dr. Tehami is a consultant gastroenterologist who specializes in hepatology and hepatobiliary medicine. He joined UHS in August 2018. He previously worked as a consultant hepatologist at Shrewsbury and Telford Hospital for over 3 years before joining UHS. He looked after patients with a wide range of hepatopancreaticobiliary problems, but he has a special interest in HPB endoscopy. Dr. Tehami's main clinical interests are HPB medicine and endoscopy teaching and training, and improving patient care through education of the health professionals and service development. He's currently MRCP PACES examiner, member of the MRCP Part 1-2 question writing group, JAG accredited endoscopy trainer, advanced life support instructor. So we would like to welcome Dr. Nadeem Tehami from UK. He's live with us from UK right now.
Yasir, thank you very much. Hi, everyone. Thank you for joining and staying with us. I would again like to thank the organizers for the kind invitation. Okay, so after many, I present you Nemo. Nemo is well and only interested in flood insurance. Now, 20 is definitely not plenty, especially for this topic, but I will try to focus on the basic concepts in hepatic cholestasis, approach to management, and we will try to focus on immune-mediated cholestasis. Why do we need to talk about it? Is because if you look at the rates of transplantation, especially if you look at the PSC, which we regard as a black box of hepatology, rates have gone up, or even though this slide is a bit old. So as I said, this is going to be a whistle-stop tour, but I will stop and take a break and will try to give you some keep home messages. So cholestasis. Cholestasis is an impairment of bile formation or flow, which may clinically presents with fatigue, pruritus, and in most overt form as jaundice. Bile production is a complex process that involves hepatocytes, cholangiocytes, and a number of different bile acid transporters, which coordinate in bile formation. There are various cell surface receptors and cholangiocytes that regulate the cholangiocyte secretion and function. So cholestasis starts at hepatocytes and ends at large bile ducts. There are myriad of processes from drug, sepsis, inflammation, and genetic etiology that lead to the presence of biliary constituents into the serum, and this is how we define the cholestasis. Histologically, you may find bland cholestasis that we see with the drug-induced liver injury, ductopenia, or lymphocytic cholangitis that we see in PBC, or classic large bile duct involvement that we see in cases of PSC. Recently, we've become more aware of IgG4 plasma cells surrounding bile ducts in IgG4 sclerosing cholangitis. So cholestasis develops after injury to hepatocytes and small and large bile ducts. We can divide it into neonatal or adult cholestatic diseases, or we can do it on the basis of histology. So histology, there are two things we are looking at. There is bilirubinostasis, and then there's a cholestasis. So if you look at the two end of the spectrum of the problems, on one hand, there's a complete obstruction, and on the other hand, on parenchymal, incomplete obstruction. So early on in complete obstruction, there will be bilirubin stasis. And classically, we've seen a case recently where there was a cholestasis within the clinic line. The bilirubin and cholate stasis does not become apparent in incomplete obstruction until very late. Clinical presentation. So experienced clinician can predict the nature of cholestasis in many cases based on careful patient history and physical examination. It's important to take drug history, ask about family history, especially if there are hereditary disorders. Some cholestatic disorders are observed only under certain circumstances, for example, pregnancy or infection, and therefore may require specific investigation, then that may not be very relevant. Now, I see this is a very basic slide, which I use for undergraduate teaching, but hopefully this will illustrate the importance of dissecting the information while we are dealing with the common presentation with or without cholestasis. We can divide cholestatic syndromes based on etiology of the cholangiopathy. Most chronic cholestasis diseases are purely intrahepatic, whereas some sclerosing, for example, sclerosing cholangitis affects small and the large intrahepatic ducts. For asymptomatic patients, mostly are generally picked up on routine tests, or if they're having blood tests for another reason. It's usually both combination of raised elevated alkaline phosphatase and gamma GT, but in some cases with the isolated, you see the isolated gamma GT, which has a very little specificity, whereas isolated elevated alkaline phosphatase is seen in cholestatic liver diseases, including certain rare disorders such as PFIC. Obviously, we do need to be aware of the bone-related problems where you see isolated rise in the alkaline phosphatase. So one of the take-home message or keep-home message slides from my talk is what are those principles that we talk about. So the principles of management are risk stratifying through use of biochemical and prognostic criteria if available. The second thing is to stage and treat the disease and monitor the progression. These conditions need to be managed actively to prevent progression and prevent development of complication. And then comes the two big C's, cancer and cirrhosis for this group of patients. The aim of therapy in most of these cases is to improve the long-term prognosis and ensure transplant-free survival. This is a slide available through EASL website, which talks about the diagnostic approach to cholestasis. It takes into account history, importance of good history examination, serology, imaging, and then histology. Now, for the next part of my talk, I'm just going to focus on two conditions. First of them is PBC, which is, as you all know, a chronic cholestatic immune-mediated liver disease that progresses slowly over time. It appears to be initiated following an immune-mediated destruction of biliary epithelial cells concentrated toward the intrahepatic bile ducts. Now, it is typically a disease of older patient with a mean age of diagnosis around 65. It remains a female predominant disease. If you look at the older studies, the difference quoted is sort of between 10:1, female is to male, but in the newer studies, there are rates quoted between 4:1. The incidence and prevalence is quite varied worldwide. The majority of the epidemiological data comes from the West. So we don't know much about the prevalence, especially in the subcontinent. However, we know that prevalence in Asia Pacific and countries like Australia is low. So this is a very interesting slide following the globalization that's happened all around us. So if this shows the prevalence of PBC in women older than 40 years, on the left-hand side are the women who were born in Australia, and on the right side bar shows the UK women living in the United Kingdom. And the central bar shows the UK-born women who migrated to Australia. In terms of, as I said, subcontinent, I've gone through the literature. I've not seen any epidemiological study, but there was a systemic review of the epidemiological studies in the Asia Pacific recently, which showed that overall prevalence of PBC is about 11 per 100,000, with the highest prevalence is in Japan and China, and lowest, as I've said, in countries like Australia and South Korea. So briefly, I'm going to show you a cartoon about the pathophysiology. So looking at the portal tracts, taking into account the risk factors, we know it leads to the T and B cell mediated injury of biliary epithelial cells, which causes this loss of protective bicarbonate umbrella, leading to inflammation, biliary fibrosis, and cholestasis. Environment is a big elephant in our virtual world. There is a complex interplay between the genetic and environmental factors which is involved in the development of PBC. There is, as I said, although there isn't much epidemiological data, but regional geographic heterogeneity does exist. So there are studies demonstrating clustering of these cases, especially in the low economic area. There are also studies pointing evidence towards smoking, gallstones, urinary tract injury. All these support that there's a relevant role of external environmental factors. There is a disease kinship with linkage of epigenetics, bile acid regulation, inflammatory cytokine pathways, and all leading toward the development of this disease process. How do we diagnose? So we require 2 out of 3 criteria. That is, if a patient has cholestatic liver blood test, positive serology, and histology. Now, the diagnostic accuracy of combination of cholestatic liver blood test and PBC specific autoantibodies has a sensitivity and specificity over 95%, which means that the blood tests lie at the heart of PBC diagnosis. And of note, there are specific anti-nuclear antibody reactivity, including SP100, GP210, which are recommended to be assessed because they can be found in patients up to 50%, and those, especially those who are AMA negative. So for reasons which remain unclear, the presence of GP210 is associated with more clinically aggressive disease. However, there are some situations where a true antibody negative disease exists, and in those cases, biopsies should be planned. So this is what a typical patient with PBC look like, including a symptom complex of pruritus, Zika complex, fatigue, some bone pain. But the key home message from this is that clinicians should recognize that severity of the symptoms does not correlate with the stage of the disease. Treatment, who should we treat? So all patients who have elevated alkaline phosphatase should be treated. Goal of the therapy is to attain biochemical response and halt the disease progression. We all know about the ursodeoxycholic acid first-line treatment, but we also know that even with the use of ursodeoxycholic acid, there was a cumulative incidence of cirrhosis of 40% over 10 years of time, which is why now we have second-line treatments available, such as FXR, such as obeticholic acid, which is an FXR agonist, which is obviously evidence-based and licensed. There are some non-licensed therapies which have been validated through through randomized control trials, such as bezafibrate, which are quite cheap to use and have a high efficacy. A brief word about the patient who have normal liver blood test but AMA positive. So in this study, out of 700, they identified over 200 patients who had cirrhosis. Up to 6% had a cirrhosis. None of them luckily died from PBC, but the key home message from this is that among patients with normal alkaline phosphatase and no evidence of cirrhosis, 5-year incidences of PBC is 16%. So even if we discharge them back to their GP, we should recommend their GP to ensure that they are followed up and have some infrequent liver blood tests. Criteria for to assess response, there are different criteria available. More stress at looking at patient at least at 1 year following starting the treatment, and the ALP remains as a surrogate marker of treatment efficacy in patients with a PBC. Those who do not achieve the response, i.e. the ALP does not improve less than the 1.67 upper times the limit of normal, they are the one where we should ensure that we are adhering, so there's a good compliance. Patient is taking medicine regularly. They're not taking with other medications such as cholestyramine. They do not have other medical problems. They are taking the dose in the correct dose, that is 13 to 15 milligram per kilogram body weight. And if despite this they're not responding, then the second line agents could be considered. Now, this is the most important slide from my presentation. Now, we know PBC is a small duct disease, therefore role of imaging is very limited. Now, I would really like you to pay attention, because I think I get asked lots of questions about overlap syndrome. And some people sort of regard interface hepatitis as a dollar sign for autoimmune hepatitis. So please concentrate. Interface hepatitis is a common and a frequently prominent feature of PBC histopathology. And if you give a patient steroid with this histology, and if they with the response to this does not really determine that your patient has an overlap syndrome. Younger patients with more aggressive disease are more likely to have higher transaminases activity, and interface hepatitis would be seen on their biopsy if you perform it. So this usually represents a high risk phenotype of PBC, and second line PBC therapies should be considered before immunosuppression in this group of patients. We talked about the biochemical response, and then that ursodeoxycholic acid should be base-based therapy, that is 13 to 15 milligram per kilogram. But again, I'll re-emphasize that please avoid misinterpreting AMA negative disease as a variant of autoimmune hepatitis with a risk of inappropriately using immunosuppression rather than initiating effective PBC therapy. So what does EASL recommend? So in terms of transplantation, so when patients, especially for the patient with PBC, when the bilirubin started to rise, and if it is 3 to 4 times upper limit of normal, then we encourage these patients, we refer these patients for transplant assessment, and we see that patients who've had a bilirubin level of, so by the time they have a bilirubin level of 6 times upper limits of normal, then they get transplanted. Now, MELD does not serve these patients really well. So PBC patients often have a low MELD compared to the other at the time of transplantation. So this is another slide which sort of emphasizes on those principles of treat and stratify, stage and survey, and actively manage. Now let's come to discuss, if we have time, hopefully, Yasser, am I doing okay for the time wise? Can you hear me? Okay, so BBC is essentially
We're a
a
little
blind
short of
spot.
time, Dr. Nadeem. So
So
please.
how am I doing for the time wise?
We're beyond that.
Good. We are beyond the time.
Yep.
Okay, so in that case, I will skip the PBC, and I think I'll just go to one last word about ensuring that patients are not inappropriately sent for ERCP. That's the one thing I would suggest. So if the patient does not have a dominant stricture and not jaundice, then they should not be sent for ERCP. Finally, just one word about patients who have PSC and you're wondering if they have an IgG4 related disease. Please bear in mind with IgG4, they usually have fleeting and migrating biliary strictures. They can have elevated IgG4, but it usually is less than 2 times the upper limit of normal. And patients with IgG4 related cholangitis do not improve with the ursodeoxycholic acid. So in conclusion, Mr. Chairman, ladies and gentlemen, we have to be aware of the challenges posed by cholestatic syndromes, and which comes along lots of opportunities. We have to ensure, though, that we follow the principles in their management, which includes risk stratification and best optimization of their care, and followed by a good surveillance of development of cirrhosis and cancer. Thank you very much for listening.
Ami, it was a brilliant talk. You are an inspiration and always continue to amaze us with every talk you give. And thank you for listening to me in the middle of your presentation and respecting that. So, the final talk for today's session is again by our very own, yes, you heard it right, our very own Dr. Farooq Khan from Leicester. He will talk on Budd-Chiari syndrome, acute and chronic. And let me summarize his credentials for those who joined us late. He's a consultant hepatologist and hepatobiliary physician at University of Leicester, trained at transplant hepatology at Leeds, and served as associate tutor for Royal College of Physicians and Royal College of Physicians, London. His list of achievements goes on and on, but as we're short of time, we would like to welcome him once again on the screen. Dr. Farooq.
Taught me about this Budd-Chiari syndrome. It is rather rare disease, but I think there are subtle and salient features that worth discussing. I'm Farooq Khan, as many of you know, consultant hepatologist in Leicester. What do we need to talk about? What are the learning points? I think we need to understand the pathophysiology. This is relatively less understood. Is it SOS? What is a sinusoidal obstruction syndrome? Is there a difference between the two? When we go through pathophysiology, hopefully, we will be able to clarify this. How do we classify this? And does it really matter? And how do we treat this? What treatment works and how we should take this forward? Okay, so let's go through pathophysiology. Now, if you look at this, we have the splenic vein and the supramesenteric vein, which then joins to go and form the portal vein, which enters into the liver. What is also worth knowing is that it's a venous flow. So therefore, if you look at the pressures, the normal pressure that goes through the portal vein is 6 millimeters of mercury. So if I were to do blood pressure, we normally see 120 over 180 millimeters of mercury, which is very high as compared to what pressures goes through the portal vein. And therefore, you and I both know that a subtle change in that pressure can slow the volume and therefore increase hypertension and propagate a thrombus. If you see more than 10 millimeters of mercury, if the pressure goes up due to any problem within the liver or within the outflow, that can cause portal hypertension and its complication. Okay, I've taken this from Sheila Sherlock's, and what I really wanted to do, just a quick outline for you to understand. This is prehepatic, this is hepatic, and this is post-hepatic. Now, this is a prehepatic blood flow, and what kind of problems happen. We will concentrate on intrahepatic in a minute, and this is post-hepatic, which is largely the content of our talk is going to be. Right, we now have liver, take a sample out. This is the general outlook. If I get my 12-year-old son to draw a diagram, this is somehow he would draw it really, where you can see the portal vein coming. This is your intrahepatic lobule, and that's the central vein that will then form your hepatic veins, which is the outflow. What is the hallmark of Budd-Chiari syndrome? So what normally happens if there is a blockage in the outflow, you could clearly see that the pressure is going to be backflow, and what you start to see is sinusoidal expansion, which then put pressure around the central lobule, and what you got is centrilobular necrosis. If this carries on, it then goes slightly further where the portal triad is, and you got peripheral ischemia. This then forms what is the classic histopathological representation of a nutcracker. So this is the basics of a nutcracker appearance of the liver in Budd-Chiari syndrome. Okay, so where does a problem occur? So if you look at the right, middle, and the left hepatic vein, that's where you can have an obstruction, or you can have an obstruction at the inferior vena cava level. And this basically then forms how we classify Budd-Chiari syndrome. Okay, so there's a primary and secondary, or there's asymptomatic versus symptomatic. What is primary? That you have a blockage right in the outflow in the hepatic vein. And what is secondary? That the obstruction is coming from out. It's a compression rather than intrinsic problem. We also have asymptomatic versus symptomatic, which is 20% of the patients, when they present, they are asymptomatic or they are late presentation. This is generally difficult cohort to deal with, and I'll come to that in a minute. You have a symptomatic, which are younger patients. They come acutely presents with abdominal pain and ascites, and this is a relatively a cohort that has got a generally better prognosis, purely because we catch them early. Right? There was a systematic review that I think is worth talking about, who actually redefined how we talk about Budd-Chiari syndrome, or how we should think about it. So there's a classic, 75% belongs to this category, mostly women, and it's usually acute onset, where you have abdominal pain and you have a tender liver. If you look at it, more than 50% of this associated with hematological problems like myeloproliferative disorders or JAK2 mutations. Medical management of this group has really good outcomes. We'll talk about this in a minute. The second group that Shin and the group have described was your non-classic, if you like, or where you have hepatic vein as well as inferior vena cava obstruction. It is more common in men. It's a chronic presentation. Really gradual onset. They don't come into attention until they have developed quite significant portal hypertension and its complications like ascites or varices or GI bleed. In these, however, not the thrombus, which is a problem, it's an intrinsic membrane or epithelial or endothelial issues here. And in these scenarios, I think early recanalization. So basically, in this group, you would need to have an invasive treatment modality on top of anticoagulation. Okay, so therefore, what defines Budd-Chiari syndrome? What are the causes? You know all the details. I'm just going to quickly touch upon hematological. By and large, it's the largest group, and that includes myeloproliferative disorders, your JAK2 mutations, protein C deficiency, all those categories comes into that. You then have infections. This is very common, and I have a slide which will tell the subcontinent where this is more of a common problem than this. And you have your infectious schistosomiasis, which also explains non-cirrhotic portal hypertension, much more common in young males in subcontinent region. You then have tuberculosis, indeed, again, very much common there. The third is your malignancy. And hepatocellular cancer, I'm afraid, by and large, is the largest account for this, but any malignancy, to be honest, could count for that. Inflammation, you Behçet syndrome, your arterial problems, vascular disease, all these comes into inflammation categories. pregnancy itself is a hypercoagulable state, and therefore then would account for certain numbers of birth carrier syndrome presentation. And miscellaneous are drugs, largely contraceptives, as we know of. Clinical presentation, Shin et al. Did a nice systematic review and presented 4 years ago in the World Journal of Hepatology, and they looked at different presentations of birth carrier syndrome and redefining them into regions. And if you look largely in the Europe side of in France and UK, you will see that abdominal pain and ascites are the most common presentations. However, if you look at Egypt, India, and China, you will see that GI bleed by and large is quite significant number. And this, well, as we said, if the presentation is acute, which is largely in the European population, then the outcome is good because you can manage it just with anticoagulation or medical therapy. Whereas if presentation is late onset, your non-classical, should you like, mostly infection related, then you will see that this is down to late presentations where you have fairly significant portal hypertension. And most of these patients, in fact, presents with GI bleed. How do I diagnose it? Is there an easy way? And I think imaging by and large plays a fairly important role. If you clinically suspect it, and I think that's entirely reasonable to ask for ultrasound Doppler. Ultrasound Doppler should really give you a fairly significant idea of where we are, and we'll talk about it in a minute. CT, MR is another modality, but please bear in mind, and it's very important that we work up for the etiology, because anticoagulation is not just the treatment, we also have to treat the cause. So 80% sensitive ultrasound Doppler, and what you see here is thrombus right sitting in the middle hepatic vein. And this you can also see in the left hepatic vein. Now, interestingly, trainees of mine who come on my EUS list, they know, and I do stress upon station 1, that you could see the left and the middle hepatic veins walking into IVC, even on your EUS. So that as the things are moving towards endohepatology, I think this will become much easier, and you could actually see the clots within the hepatic veins, even on EUS. 90%, if you put the Dopplers on, you have sensitivity and you should be able to catch it. Is ultrasound better than CT in diagnosing this? I think the answer is yes. Sometimes it's much quicker and readily available and should therefore be first-line investigation. Okay, if that is the case, do we actually need a CT scan? I think yes. Why? Because it gives you cross-sectional imaging. It would also give you much more information if there's another pathology, particularly malignancy. And also the third point, which is very relevant for IR colleagues of mine, it allows a roadmap and they can plan intervention in a more appropriate way. I'll talk about intervention in a minute. What are treatment paradigms? Now that we know clinically that's how it presents, what can be done for the diagnosis? We've now diagnosed it. How do we treat it? Okay, if you look, birth carrier syndrome, by and large, the most common treatment is anticoagulation. Sometimes we do go for conservative management, but I think about 80 to 90%, I would urge you guys to consider anticoagulation. Acute scenarios, thrombolysis have got some point, but this isn't really very common part of the treatment. This is IR intervention, guys, where you do angioplasty and stenting. I'm trained in Leeds for my transplant, and this is a fairly common thing happening in much more transplant centers these days, rather than going straight for tips, which by and large remains an option. And if all of this fails, then you can always do transplant as a treatment modality. Is transplant any better than this? We will discuss that in a minute. And if you go through the stepwise strategy, you will see the CJO have actually looked at the cohort of patient where he's gone down to the stepwise fashion, try anticoagulation. If that doesn't work, you then go to IR and see if you could possibly do stenting for the blocked hepatic vein, or even angioplasty, just dilate it a little and see if that improves the flow, or TIPS. And what he's actually proven by adapting to this, that there's more than 80% 5-year survival, and not just the survival for these patients, actually transplant-free, so they didn't really need a transplant if you have adapted to this stepwise approach. Okay, so what is the medical management? All patients, regardless of whether they're acute, whether they are chronic, I think it's very reasonable to at least consider anticoagulation and discuss with the hematologist. Please, I cannot stress upon more than make sure that you do consider working out for the etiology, because that's by and large is very important. The prognosis of the bed carrier syndrome is actually improved with the use of anticoagulation. And the overall survival rate of 10% at 3 years is without treatment. So if you look at the Simon Travis paper, if you don't anticoagulate them, then there's overall survival of only 10%. And that is serious, really. So there is a significant mortality if we don't intervene in time. I'm just going to share this study with you where there was 140 patients. They randomized 80 patients just to the medical management and not have any intervention, which include angioplasty, stent replacements, surgical shunting, or TIPS. And look what they found. The overall survival rates were very, very comparable in both groups, even the transplant survival. So by and large, if you work in the center, if you sit in the far-flung rural setting where you don't have extensive IER facilities, not have many interventions available, there's not to panic really, because we now know that even starting anticoagulation in the right group of people at right time is equally effective as your interventions are. And of course, if that doesn't work, you then move them to the higher. So stepwise approach, and you then refer them to higher centers. Angioplasty, just a quick word, I'm not an IR radiologist, but I just wanted you to show, as you can see, there is a complete blockage there, and they pass, the balloon stented it, and you can see there's a very decent flow going across. TIPS. Important, I think, in patients where the stenting cannot be done. I don't think we should straight jump to TIPS, but again, a lot of this depends on your local abilities and competencies. The other benefit of TIPS is that it has replaced surgical shunting in these patients. Surgical shunting was a treatment modality quite a long time ago when TIPS weren't available. However, since it has come, there are a lot of patients who have even managed to survive, and not just the surgical, but even if you look at this 5-year survival after TIPS, 84% of the patients have a similar 5-year survival to even transplant. So I think before you consider transplant, it's really worth asking yourself whether it is worth consider this patient for TIPS. Transplant, yes, I think it is last resort. Please don't go straight for transplant. There are other modalities we've discussed we can try. It's indicated only if there is a rapid progression despite you've tried everything. However, it is a treatment of choice, and the 5-year survival for bud carrier syndrome is easily up to 80%. So if you have failed, please do not be shy of referring your patient to a transplant center. Early mortality post-transplant, if you look at this, is related to infection, and late is mostly due to recurrence. So please, once you have referred your patient to transplant, when he has had a transplant done, and he comes back to you, make sure he's on anticoagulation. By putting him on transplant doesn't necessarily mean the job is done, because as you can see in this paper, that the late failure of transplant and the mortality in this group is down to recurrence PSH. Hence, anticoagulation should be continued post-transplant. Okay, couple more slides before you finish, and I think I really wanted to touch upon this prognosis-wise. What defines prognosis? I think if you're young age, low Charles P, you haven't quite gone into the chronicity of portal hypertension, i.e. a GI bleed or no ascites, then I think the chances or the prognosis is extremely good. There is a formula available that you can try. It's on the website. A score of less than 5.4, if that comes, that generally have a good prognosis and outcome for these patients. And I just wanted to finish with this flow chart. If you suspect BCS, confirm it with ultrasound and start anticoagulation. Is there a disease progression in the next step? If no, then that's fine. You just carry on following these patients. Initially, I follow them up monthly, but then you can go to 3 or 6 monthly. Now, if there's a disease progression, where do I go? Is if the patient is moving into acute liver failure, I do not think there's much time there for us to do straight refer for transplant. If not, then you should evaluate whether he's a candidate for stenting or if he's a candidate for TIPS. And if there's even a single vein available, I think trying for TIPS would be a reasonable idea. If there isn't, then I think you should go for transplant. But this, all of this in this flowchart is done at a very high level centers. And if your patient has not responded to anticoagulation, if it progressed, I think the bottom line is that you don't hold on to him and ask for help and refer him to intervention or even transplant centers. Thank you very much for listening. I will finish here and we'll take questions at the end of the session. Thank you very much.
Another beautiful talk by Dr. Farooq Khan, and a very healthy discussion going on in the chat section. I was thoroughly enjoying. Burning questions were raised and they were answered beautifully by our panel. So with this, we reach the end of this session, and I would like to thank everybody who spared time and came to attend the lecture, especially our panelists. And now I would like to hand over the mic and screen to Dr. Professor Kashif Malik to please say a few words so that we can hear that.
So thank you very much, Yasir. It was a very good session, and but with the constraints of time, we cannot take the question answer session. I would like to invite my panelists, especially Dr. S.M. Munir and others, if they have some comment before concluding this session. Yes, sir, can you hear me?
Sir, can you say that? So I missed your last line.
Yeah, just ask the panelists to give their remarks and to conclude the session.
I would like to welcome our panelists to...
as there are... Yasir, there are no panelists available as given in the program, so I think you can call off the session so that we start the next session. Thank you very much.
Thank you very much, Professor Altaf. With this, I humbly announce the end of the plenary session. It was a pleasure having you all with us. Next, we have a debate, a very hot debate on which will be conducted by Dr. Amna Subhan. So, hoping to see you in the next section. Thank you very much, everybody.